Okay, I think we'll get started. So welcome everyone to the IARS virtual education webinar, Sleep and Circadian Disruption, Risk Factors and Pathological Pathways for Delirium and Neurocognitive Dysfunction. So this webinar has received no commercial support. CME is available for this webinar to IARS members. Please join us in April for the IARS 2023 annual meeting, which will start in May for calls for sessions, and that will be open for the 2023 annual meeting. So don't miss this opportunity to turn your ideas into a session. The IARS 2020 annual meeting recordings are still available for viewing. Please go to the registered link there. After this webinar, join the speakers in the IARS Doc Matter community to continue the conversation. And a recording of this webinar will be available to IARS members by the end of the week. And please submit questions via the Q&A button below. You will receive an email after this webinar with information about CME. And then without further ado, it's a privilege of mine. My name is Dr. Lei Gao. I'm from the Mass General Hospital in Boston, and I'll be introducing today 4 speakers who've kindly agreed to come and talk about their work. So first up is Dr. Michael Devinney, Assistant Professor of Anesthesiology at Duke. His work focuses on disrupted perioperative sleep disturbances, obstructive sleep apnea, and neuroinflammation as potential mechanisms for postoperative delirium and cognitive dysfunction. This work includes the completion of a prospective observational cohort sub-study called Sleep Apnea, Neuroinflammation, and Cognitive Dysfunction manifesting after non-cardiac surgery, called the Sandman study, which we are excited to hear more about this afternoon. Reine Ibala is a third-year MD MPH candidate at Weill Cornell Medical College and Harvard Chan School of Public Health. With Dr. Oluwaseun Akeju's lab at the Mass General, she examined neurocorrelates of sleep and consciousness and the use of polysymptomography to examine the relationship between sleep and postoperative delirium in cardiac surgery patients. Within this vulnerable cohort, she also hopes to leverage her global health and humanitarian studies to explore racial health disparities in cardiac surgery management. And next, we have Dr. Melissa Knauert, who received her MD and PhD from the Yale School of Medicine. She completed an internal medicine residency at the Hospital of the University of Pennsylvania, as well as pulmonary critical care and sleep fellowships at Yale School of Medicine. She joined the pulmonary critical care faculty in 2013, has been a PEPR and YCCI scholar. She's currently supported by an NHLBI K23 award and the Doris Duke Fund for clinician scientists. She has interests focused on acute sleep deprivation in the ICU, atypical ICU sleep, and ICU circadian disruption. And finally, we have Dr. Elizabeth Wilcox, who is an associate professor at the University of Toronto, attending physician at the Toronto Western Hospital. She completed medical school at the University of Calgary, internal medicine and adult critical care residencies at the University of Toronto, a master's degree in health services research at the London School of Tropical Medicine and Hygiene, and a doctorate of philosophy in medical sciences at the University of Toronto. So her work currently focuses on the short and long-term effects of critical illness on neurocognition. She recently conducted a multi-center cohort study that evaluated the association of genetics, EEG, and sleep on cognitive outcomes in ICU survivors. And so with that, I look forward to a wonderful discussion on this important topic.
Hi, everyone. My name is Mike Devinney, and today I'll be talking about our Sandman study, which investigates the role of untreated sleep apnea and neuroinflammation and postoperative cognitive dysfunction in delirium. I'm an assistant professor in anesthesiology and critical care at Duke University, and I do have funding from FAIR, which funded the Sandman study, as well as funding from the National Institute of Aging. and my spouse owns an equity share in our employer that makes personal care products, but are not the topic of any of my research. Today, I'll be talking about delirium and postoperative cognitive dysfunction. Delirium is an acute change in attention, cognition, and awareness that typically occurs 1 to 3 days after surgery. Postoperative cognitive dysfunction is characterized by cognitive deficits that occur weeks to months after surgery. They typically require neurocognitive testing to find. Both of these things, both delirium and postoperative cognitive dysfunction, are associated with decreased quality of life and increased mortality. And thus, there is substantial interest in finding ways to prevent these common postoperative conditions. One potential way to prevent it could be the treatment of sleep apnea in older adults. Because sleep apnea is commonly undiagnosed and it's highly prevalent in older adults. Further, sleep apnea has been associated with increased likelihood of developing mild cognitive impairment, dementia, and Alzheimer's disease. And it has been associated with increased Alzheimer's disease pathology. Sleep apnea, as you well know, is characterized by apneas due to central apneas or obstructive apneas that can decrease oxygenation and cause arousals during sleep. So in a sense, sleep apnea itself is a sleep disruptor, and the intermittent hypoxia can also evoke things like neuroinflammation and blood-brain barrier breakdown. So both of these things can contribute to cognitive dysfunction in sleep apnea patients. And there's a multitude of other potential mechanisms that can contribute to cognitive dysfunction, whether it's in surgical or non-surgical cohorts. So it really raises the question, is sleep apnea associated with postoperative cognitive dysfunction? So our primary hypothesis is that increased sleep apnea severity, as measured by apnea-hypopnea index, will be associated with decreased global cognition at 6 weeks after surgery, or increased POCD severity. We also hypothesize that sleep apnea severity is associated with increased postoperative delirium incidence and/or severity. And then finally, we hypothesize that sleep apnea severity is associated with increased neuroinflammation as measured by preoperative cerebrospinal fluid cytokines. And to accomplish this, we enrolled 101 patients from my mentor's study. These patients were aged greater than 60 and not treated for sleep apnea within the last 3 months. After they were scheduled for non-cardiac surgery, they underwent baseline cognitive testing, home sleep apnea testing, and we measured their Epworth Sleepiness Scale, or subjective sleepiness, as well as collected blood and CSF. 24 hours after surgery, we repeated the collection of blood and cerebrospinal fluid, and delirium assessments were performed every 12 hours up through postoperative day 5 or hospital discharge. 6 weeks after surgery, patients returned again for the cognitive testing battery, and we obtained CSF and blood at that time as well. Overall, 96 patients out of the 101 completed home sleep apnea testing. And so we had a pretty good rate of completion. And what we found is that many patients have undiagnosed, untreated sleep apnea. Many older surgical patients, 60% of them had some form of sleep apnea, 36% mild, 14% moderate, and 10% severe. The way we diagnose the sleep apnea is using this commonly used device called ResMed Apnea Link Air that measures airflow through a nasal cannula, respiratory effort through a chest belt, as well as oxygenation through a pulse oximeter not shown here. And we saw that our recordings are pretty good quality. Patients were anywhere between 6 to 8 hours typically. And the recordings were done typically the week before surgery. We had the patients bring them back the day of surgery. After the device was brought back to us, we had it interpreted within the next few weeks, and then they were arranged for follow-up evaluation and treatment. And virtually none of the patients had treatment prior to their 6-week cognitive testing. So we had very little confounding by treatment. Another interesting factor between groups is that there was really no difference in subjective sleepiness between groups. This is pretty well known that there's not a one-to-one correlation, but we really saw no difference between severe sleep apnea and no sleep apnea in terms of subjective sleepiness. So what are our results for sleep apnea and postoperative cognitive dysfunction? Well, here on the x-axis, apnea-hypopnea index. Here on the y-axis is 6-week global cognitive change. These patients perform worse at 6 weeks, so they would have increased POCD severity or severe POCD patients. You can see there's no clear relationship with apnea-hypopnea index and cognitive performance at 6 weeks. And if we build this into a model adjusting for sex, baseline cognition, and age, we can see that apnea-hypopnea index has no relationship with 6-week global cognitive change or POCD severity. This really suggests that sleep apnea is not a major risk factor for POCD, which is surprising. And even if we look at categories and look at the most severe sleep apnea patients compared to no sleep apnea, we see no really general trend that these patients are performing worse, and no statistically significant effect of sleep apnea on cognitive performance at 6 weeks. So what about delirium? Well, we had about 9 patients test positive for delirium, shown here, an apnea-hypopnea index on the x-axis. And you can see these patients had really no clear differences in their apnea-hypopnea index compared to the patients who did not test positive for delirium. And if we instead look at a delirium severity scale, which really captures the range of delirium severity, including patients who score 1 or 2 points and have subsyndromal delirium or just isolated effects on attention, we see no relationship of apnea-hypopnea index with delirium severity following surgery. If we build this into a model adjusting for sex, age, and baseline delirium severity, again, there's no effect of apnea-hypopnea index on increased postoperative delirium severity. And even if we adjust, not shown here, for surgical duration and baseline cognitive cognition or baseline cognitive index, we again don't see any effect of AHI. So this really suggests that sleep apnea is not a major risk factor for postoperative delirium either. Surprisingly, though, we also collected data on excessive daytime sleepiness by performing the Epworth Sleepiness Scale, which basically measures the patient's reported likelihood of falling asleep during routine activities they do throughout the day. Patients that had moderate to severe excessive sleepiness, or an Epworth Sleepiness Scale of 13 or greater, were at increased risk of having a delirium severity score increase compared to patients who had normal excessive daytime sleepiness or no excessive daytime sleepiness. And so this suggests that excessive daytime sleepiness may predict increased risk for delirium. We did not see any significant results with delirium incidence, but as you probably noted, we only had 9 patients, or 10% of our patients test positive for delirium, so not a significant amount of statistical power there. So I think this warrants a future study investigating the role of excessive daytime sleepiness in delirium. And this suggests that potentially maybe sleep deficits, or some sedating medications, or some other psychosocial factors affecting sleep health, or potentially even prodromal neurodegenerative disease that could impact overall sleepiness could be at play here, increasing delirium risk. And I'm interested to hear what the other speakers in this panel, they will be talking about sleep disruption and delirium, and that will be a very relevant topic. So overall, our conclusions are that untreated sleep apnea is not a major risk factor for postoperative cognitive dysfunction or delirium, and that excessive daytime sleepiness might indicate increased risk for postoperative delirium, but further study is needed. So I'd like to acknowledge my funding source, FAIR, funded the Sandman sub-study. I'd like to thank my mentor, Miles Berger, for allowing me to perform the Sandman sub-study and his NIH K76 funded Intuit study. I'd like to thank the rest of my mentors for their insight and guidance, and the whole team for carrying out this study. It's been an honor to present on this panel with really great, wonderful speakers, and look forward to hearing your questions in the Q&A panel. Thanks.
Hello, everyone. My name is Reine Ibala, and I, as Dr. Gao was kind enough to share, am a current MD candidate at Weill Cornell Medical College. It's an absolute honor to be speaking here today and sharing the stage with some of the forefront leaders in the field and learning from them as well. As we know, sleep is such a complex topic, and in some ways, we barely skimmed the surface in our understanding of it. Now, Dr. Devinney just gave a wonderful presentation on sleep apnea and cognitive disturbance in non-cardiac surgery patients. I'll be continuing the conversation with a discussion on the relationship between sleep disturbance and postoperative delirium in hospitalized cardiac surgery patients. I have no disclosures. So a quick overview of what we'll be discussing today. First, I'll be going over some of the history on delirium research and our current understanding of it today, followed with some work that I did investigating sleep and delirium during my time at MGH under Dr. Johnson and Cage's team prior to medical school. And I'll be closing with some future directions for research. So our first recorded published article on postoperative delirium was actually by Dr. P.D. Bedford in 1955 from the University of Leeds. Bedford noted anecdotes from family members saying that their loved ones had never been the same after an operation, and conducted a chart review of over 1,200 surgical patients, with 1/3 of whom ended up experiencing cognitive dysfunction postoperatively. He hypothesized that the pathogenesis of postoperative delirium could be threefold, mainly potentially pertaining to cerebral circulatory dysfunction leading to anoxia and brain damage, or it could be due to drugs causing cerebral hypoxia, and perhaps an etiology secondary to neurometabolic dysfunction. Then in 1995, a systematic review of 80 articles from 1966 to 1992 was published by Dyer et al., where they defined postoperative delirium as an acute change in cognitive status, characterized by fluctuating consciousness and inattention, occurring within 30 days after an operation. What we're going to come to see in the next slide, and as Dr. Devinney spoke a little bit of, a lot of this definition has not changed over the years. What has changed is our understanding of the mechanisms and also risk factors associated with the disorder. In their article, Dyer et al. Stated that sleep deprivation and gender were not associated with postoperative delirium. On the other hand, today's DSM-5 definition, as well as evaluation criteria in our most recognized and standardized diagnostic tool, the confusion assessment method, rely on the same 4 domains for diagnosis as were discussed in Dyer et al.'s article. Over the years, one of the key factors in postoperative delirium definition that has changed is the timeline. Most currently, it is considered to be within 10 minutes of general anesthesia administration and up to 7 days or discharge, with, again, the first 3 postoperative days being the most keen for that diagnosis. As for our current understanding of risk factors for delirium, while we maintain that age and preoperative cognitive impairment are important, we now know that male sex has come to demonstrate a stronger association with incidence of delirium. And most relevant to our talk today, sleep has emerged as a key modifiable risk factor. We know that interventional studies targeting delirium have shown that environmental interventions promoting sleep, such as decreased noise, reduction, dimming lights, using earplugs, have been shown to decrease the postoperative delirium incidence. In fact, Kamdar et al. Showed a decrease in the incidence of about 20% in 2013 using these interventions. Now, my fascination with this topic began with one of my first studies at MGH, a meta-analysis on the relationship between sleep disturbance and postoperative delirium. Along with Dr. Ayo Fadayomi, I reviewed studies from 2001 to 2015, and we noted and showed that preoperative sleep disturbance conferred a 5 times greater risk of developing postoperative delirium. Amongst our findings, we saw that postoperatively, decreased sleep and increased sleep latency on postoperative day 1 were associated with increased incidence of postoperative delirium in orthopedic surgery patients. And preoperatively, it seemed that higher wake after sleep onset was associated with delirium. Throughout the article, some of the things we noted was that there were few EEG and polysomnography studies. When they were used, they predominantly focused on postoperative sleep evaluation. Also, the literature seemed to remain inconclusive as to whether or not the neural hallmarks associated with preoperative sleep disturbance in patients that subsequently developed POD was conserved in a hospitalized setting. And lastly, many of the articles were conducted on non-cardiac surgery patients, although we know that sleep is a key factor in developing cardiovascular disease. So the question I kept coming back to was, is this association between preoperative sleep deprivation and postoperative delirium conserved in hospitalized patients, particularly in cardiac surgery patients? Because I was so intrigued by this question, I wanted to conduct a study exploring it further. So I worked with my team to design a polysomnography study. And we had a single site prospective pilot polysomnography study where we enrolled 22 subjects, 16 of which ended up having clean EEG data for analysis. We enrolled patients that were inpatient and over the age of 60 who were scheduled for non-emergent cardiac surgery using cardiopulmonary bypass, mainly only dropping patients that were intubated greater than 24 hours in order to permit improved delirium evaluation. Outside of the cohort being mainly male, there were no significant demographic differences in our patient cohort. As for our study design, the night before surgery, we used the confusion assessment method to establish a delirium baseline and the Pittsburgh Sleep Quality Index for a baseline of self-reported sleep disturbance. We also conducted the polysomnography study that night. Patients then were scheduled for surgery on postoperative day 0 the next day, and we conducted twice daily delirium assessments for the first 3 postoperative days. We use 4 channels for our polysomnography data, mainly 2 frontal and 2 central, according to the American Academy of Sleep Medicine practice standards, and maintain lights on at 4 a.m. for those with morning surgeries and 8 a.m. for those with afternoon surgeries. We use Markov chain modeling to account for this difference in wake times in our analysis. In terms of our results, so firstly, our cohort showed a much greater incidence of delirium than commonly published in the literature. In non-cardiac patients, often the literature cites a prevalence of about 12 to 17% of those who end up developing delirium for an incidence. In our cohort, 45% of our patients completing the study ended up developing delirium, and 50% in those that actually had clean PSG data. We didn't find a significant difference in the self-reported sleep, preoperative sleep, as evaluated by the Pittsburgh Sleep Quality Index. Now, in terms of our polysomnography data, we showed that patients who were hospitalized showed a decreased sleep duration and impaired sleep efficiency as compared to non-hospitalized patients. Normally, normal adults are seen to sleep between 7 to 8 hours and have a sleep efficiency of about 85%. Our cohort of patients were sleeping anywhere between 4 to 5 hours and had a sleep efficiency sometimes as low as 28%. We also, however, showed that amongst this hospitalized cohort, those that ended up developing delirium had actually a greater sleep efficiency and showed an increased median sleep duration, mainly in the N2 stage. They also showed reduced sleep onset latency and decreased wake state probability. And we confirmed these with our Markov chain model. So in summarizing our findings, we showed that hospitalized cardiac surgery patients exhibit decreased sleep duration and sleep efficiency as compared to non-hospitalized patients. Interestingly, amongst hospitalized patients, it seems that those who actually slept longer were more likely to develop postoperative delirium. Now, the literature often describes the relationship between sleep and delirium to be associated with sleep deprivation, which is linked to neuroinflammation, oxidative stress, and circadian rhythms, which will be discussed by Dr. Knauert after my presentation. However, in a 2016 review by Irwin et al., it was actually found that sleep disturbance and longer sleep duration were associated with elevated inflammatory markers. In addition, Rogenbach et al.'s paper in 2014 proposed a mechanism of reperfusion injury secondary to the oxidative stress from sleep-disordered breathing. And this, having an increased amount of oxidative stress from longer sleep duration, could be also the reason why hospitalized patients may be at increased risk of developing delirium. These findings intimate a need for further investigation, mainly looking at the question that still remains of what constitutes normal sleep for hospitalized patients, and also the need to explore microstructure dynamics with high density PSG so we can better predict who might be at increased risk for developing delirium and require early intervention. I'd like to thank definitely my mentor, Dr. Oluwaseun Johnson-Akeju, who allowed me to be able to conduct the study, and Dr. Lei Gao for involving me in this panel. It's been a pleasure speaking with you all, and I'm looking forward to answering any questions after.
Good afternoon. My name is Melissa Knauert, and I'm pleased today to join you from Yale University School of Medicine. Today, I'll be talking about sleep deficiency in the ICU, environmental sources of sleep and circadian disruption leading to delirium. I've listed my conflicts of interest. None of them have influenced the content of this talk. Today, I'm going to present environmental disruption in terms of 2 broad categories. One is types of environmental disruption that lead to a disruption of sleep opportunity. And the other is environmental disturbances that cause circadian miscues. Starting with sleep opportunity, which is, I think, also where the field started, We'll touch upon sound and light and care events that can lead directly to sleep interruption in the ICU. First of all, we have a rich history of really decades of investigation into ICU sound levels. And though the jury remains out as to what aspects of sound might be most important for sleep, is it variability? Is it sound peaks? Is it the average? We do know that we are consistently across the decades, and perhaps even getting worse, at exceeding the World Health Organization recommendations that we have a maximum sound level in hospitals of 40 decibels and an average sound level in hospitals of 30 decibels. Similarly, there's been a growing investigation into light levels in the ICU, and this is a very nice summary plot by Fan et al. Reflecting some of the light levels in their ICU. We start here on the x-axis at midnight. We go with time to midnight of the next day. And then on the y-axis, we have lux, which is a measure of light intensity. The thick black line indicates the median lux, and the gray shading on each side of the line, the interquartile range. And what you can see is that we've actually become relatively good at decreasing light overnight, and that those levels are overall quite low. But we have also have very low light levels during the daytime, and we'll circle back to why this is important in the next section. Finally, care interactions are quite important in the ICU, and this is a very brief table summarizing a body of work that I did looking at room entrances and exits and trying to get a sense of how often patients were interrupted in their room by a staff member. And here what I've highlighted is, though there are various time blocks listed, 8 p.m. to midnight, midnight to 4, 4 to 8, and then 8 to noon, in that true core of the night, midnight to 4 a.m. time period, when I asked the question, how long on average is it between visits to the room by staff members? It's only 28 to 29 minutes. And so these very brief blocks of time for patients to attempt to get sleep. This builds on a rich body of work showing 40 to 50 care interactions per night for patients, and fits, I think, in with our intuition of how frequently patients are interrupted while they're admitted to the ICU. Moving on to the circadian cues, or rather miscues, as I labeled them earlier, we need to circle back to light and really think about how light and entrainment interact and how important that can be in the ICU, as it is for all folks. Also remembering that while light is the key Zeitgeber, it is our photic Zeitgeber, there are many non-photic Zeitgebers, and they include sleep-wake themselves, how we feed and on what schedule we feed, immobility, and social and cognitive tasks, all of which are quite abnormal in the ICU. So circling back to light, this is a very granular look at light levels in the ICU. This is from about 100 patient nights at Yale. On the x-axis, again, I have time starting in the early evening and going till morning. And on the y-axis, I have proportion or percentage of light. What each bar represents is the proportion of light, a proportion of the hour listed that light was at or above the indicated light intensity. So what you can see is that during the evening, we lose overall light above 100 or 250 lux. And so you have a sense, just like we had from the Fan et al. Figure, that light in general, most of the hour is absent. However, what is not changing, or not changing significantly during the early evening into the night period, is those higher intensity greater than 1,000 lux levels. And that is really static at about 10% in this particular set of data. And so the implications of that for entrainment, as well as for sleep opportunity that I mentioned earlier, I think are important. Similarly, in the morning, we don't see an increase in those bright light levels that we would need for entrainment, recapitulating what we saw in the Fan et al. Figure, that we can't accomplish either overnight dim light or daytime bright light. Similarly, there hasn't been much consideration of light spectra in the ICU. And so for light and normal entrainment to occur, we need to think about the duration, timing, intensity, and spectra of the light that our patients are exposed to. So in this case, I have plotted out 4 almost overlapping lines that represent morning, noon, afternoon, and full solar dark. The gray line is full solar dark. and looking at the spectra at the angle of gaze for our patients. And there's a notable absence in relative intensity in the 460 to 480 nanometer range, which is that blue circadian active light. And I've highlighted that with a blue box here. So this is an important consideration. Again, I would hypothesize that in many ICUs, this is similar, and that our artificial lights are not delivering light to the angle of gaze as we would wish, even with exterior windows as we have in our ICU. Moving away from light and into our non-photozeitgebers, I want to raise sleep-wake itself as an important signal to the circadian system. Here in this illustration, I have a normal adult sleeper in a hypnogram at the top. Gray indicates sleep, and then the dark gray line indicates stage, which is listed on the y-axis. And you see here we have a typical normal adult who goes through typical sleep stages with brief wake after sleep onset. What I want you to notice is in the ICU patients 1 through 4, we have light sleep stages. We have a great deal of white representing wake after sleep onset. And we have really, in the case of patient 3 and 4, really constrained sleep duration. This itself is an abnormal circadian signal and an external cue as far as the circadian system is concerned. I also raise feeding as an important external cue that is giving a missed signal or a miscue to our alignment. So it's quite typical in ICUs to feed continuously over 24 hours. And while there has been a move to intermittent feeding with concerns for stretch receptors and normal hormonal regulation of the gut, there's been very little attention to time-restricted feeding in the ICU, which I think is quite important for circadian alignment. And finally, I'll raise mobility, which is, again, like care interactions, a very messy cue because it involves social interaction, greater deals of light because you're up and out of bed, as well as exercise itself. And this is another cue that I think can be leveraged for the ICU. So bringing it all together in a model, I believe these sources of environmental disruption lead to sleep and circadian disruption. These entities, of course, interact with each other and one can feed off the other. Ultimately, this leads to delirium. And I would be remiss to not highlight the bidirectional nature of the relationship between delirium and sleep, as well as with the environment, leading to overall a quite complex model. With that, I'll thank you. We'll take questions later in the talk.
My name is Elizabeth Wilcox, and the title of my talk is Sleep, Circadian Disruption, and Neurocognitive Impairment After Acute Illness. I have no conflicts of interest. Cognitive impairment after critical illness is very common and affects all ages. In a general ICU patient population, it's estimated that at the time of hospital discharge, approximately 2/3 of patients could have cognitive impairment that equates to mild to moderate dementia. Deficits experienced are most commonly in memory and executive function, but they can be significantly broader. Despite varying time to follow-up and different measures used in assessing cognitive function in the variety of cohort studies that have been published to date, it would seem that for many of our patients, these deficits are persistent. Now, sleep disturbances are also extremely common after critical illness. And this is a systematic review that was led by Marcus Altman and Melissa Knauert. The prevalence of sleep disturbances after surviving critical illness ranged from 50 to 67% within 1 month of hospital discharge in ICU survivors. At 1 to 3 months after hospitalization or an ICU stay, between 1/3 to 2/3 of survivors had persistent abnormal sleep. And at more than 6 months follow-up, although none of these studies applied multiple measures over time, so they were just assessed at that one time point, the prevalence of sleep disturbance ranged from 10 to 61% in ICU survivors. Now, there's a reasonable amount of existing literature outside of the critical care setting that relates sleep, circadian disruption, and poor cognitive performance. This happens to be one of my favorite studies. It was led by Andrew Lim while he was at Tufts, and they used actigraphy to study the association of sleep fragmentation and cognitive decline in 700 older community dwelling, otherwise healthy adults without any pre-existing dementia. And in this study, they found that increased sleep fragmentation, shown in the upper right-hand graph, was associated with a 1.5 times higher risk for the subsequent development of Alzheimer's disease. In a separate analysis shown in the bottom right, a higher level of sleep fragmentation at baseline was associated with faster decline in overall global cognition. Given that cognitive and sleep disorders are common after ICU, we ran a multi-site prospective longitudinal cohort study called COGWELL to better understand the relationship between sleep and cognition after ICU. Now, this slide serves as both a flow diagram for the study as well as a very modest consort diagram. In total, we screened 415 patients that were deemed to be eligible for the study and enrolled 150. Our inclusion criteria were that the patients were ventilated for more than 72 hours and were 18 years of age or older. We collected the Pittsburgh Sleep Quality Index, so a marker of pre-existing or pre-dating ICU admission sleep quality. And we did the IQ code short form to assess for pre-existing cognitive impairment. We collected a slew of clinical parameters, including the CAM-ICU while they were in the ICU. Unfortunately, 21 patients died before ICU discharge, but we followed up patients at 1 week post-ICU discharge and then again saw them at 6 and 12 months. At 1 week post-discharge, we performed formal cognitive testing, including the R-bands, the trails A and B, and the tics. We asked patients to have a EEG, so a routine EEG. We collected up to 10 days of actigraphy data. We collected blood for gene testing, biomarkers, and neurofilament 1, and asked them to also complete depression screening questionnaire. Of the 129 survivors, over 100 patients were evaluated. Unfortunately, patients felt very overwhelmed at this time point while they were on the ward to complete all of the tests. And then at 6 months, we assessed 69 survivors, and at 12 months, we assessed 39 survivors. And at 6 and 12 months follow-up, we performed, again, the R-bands and EEG actigraphy, sleep quality questionnaires, and drew blood. Our cohort had a median age of 57 years, 44% were women, 55% completed varying degrees of post-secondary education, and in fact, we had 2 university professors. 60% of patients had existing comorbid conditions. The patients were pretty sick with a median Apache 3 of 60 with an interquartile range of 45 to 80, and patients on average were in the ICU for about 2 weeks. The cognitive trajectories observed in our cohort were similar to those published previously. At 7 days after ICU discharge, 60% were classified as having cognitive impairment, and we saw significant improvement in cognitive performance over time, with only 30% of patients being impaired at 6 months and 23% at 12 months. Again, the majority of gains were seen between the 7-day and 6-month follow-up time points. Actigraphs were worn on average for 5 days at each time point. Although longer recordings do result in better estimates of circadian rhythmicity, 3 to 5 days is really typical of longitudinal actigraphy studies in other patient populations. This table summarizes our actigraphy estimates for sleep and circadian rhythm. The mean actigraphy inferred total sleep time was approximately 6 hours at 7 days post-ICU discharge. And that improved to 8 hours and 8.4 hours at 6 and 12 months, respectively. Sleep efficiency improved from a mean of 44% to more than 65% at both 6 and 12-month follow-up. And the mean actigraphy inferred sleep fragmentation was approximately stable over time. In these graphs, we show the composite global performance of the R-bands as a function of total sleep time, sleep fragmentation, labeled here as PRA, and interstability, all of which were explored by linear mixed models, adjusted for education and severity of illness. And what we found was that increased sleep fragmentation was associated with worse cognitive performance at 7 days of ICU discharge, whereas none of the other sleep variables were associated with cognitive performance at any of the other time points. Higher levels of education seemed to be protective and was associated with better cognitive performance across all time points. So the main findings of our studies were that sleep was of short duration and highly fragmented 7 days after ICU discharge, that higher levels of sleep fragmentation, so highly interrupted sleep, was associated with lower scores on cognitive testing at the 7-day time point. Sleep at discharge didn't seem to predict longer-term cognitive function, and sleep at later time points, although it did improve, didn't seem to be associated with cognition at that time. Now, you could interpret our study as being that poor sleep in the hospital is only transiently important with no long-term sequelae, but really several lines of evidence really does suggest that sleep does remain important, and we should probably address it in the ICU, on the hospital wards, and in the post-ICU recovery phase. It's important to note that our cohort had a high mortality rate, which raises the possibility of a survivor effect, and that further larger studies are needed to really ascertain the true relationship between sleep and persistent cognition. Thank you so much.
So thank you everyone for that. That was wonderful. So before I jump into the questions, I think the speakers have really shown us how important yet nuanced perhaps the relationship between sleep, circadian rhythms is with delirium and cognitive impairment. And this was shown both during surgical periods and across the spectrum of critical illness. And it's clear that the exact relationships and therefore mechanisms probably still remain unclear. Another point I would add is, the majority of our bodily functions are governed in some way by our intrinsic circadian rhythm or our body clocks. The sleep-wake cycle is probably the most obvious and it's well studied, but it's not the only one. And, we've talked about timing of activities, feeding, for example, all are very important cues. And so the question really is, should we be paying more attention to how these processes are affected both before and after surgery and during acute illness. With that, I'll head on to some of the questions. And I think first we have for Dr. Devinney, how controlled was the anesthetic administration for the patients studied? And there's another one that says, is 100 patients enough power?
Yeah, happy to answer that. And I really didn't have time to kind of delve into the cohort characteristics, but this is a cohort of age greater than 60 patients undergoing non-cardiac surgery, which included thoracic, general surgery. About 40% were actually orthopedic surgery, and we had some plastics and urology. And we required that they be posted. We only recruited patients who were posted for an inpatient stay. So in 2 hours, the surgical duration of at least 2 hours. Most of the patients ended up getting general anesthesia. We did not put limitations on the anesthetic care because otherwise it wouldn't really be generalizable to kind of the population, and we wanted to kind of be able to include as many patients as possible. And I didn't have time to go into all the cerebrospinal fluid data, and we're still working on analyzing that, but obviously we wanted to be as inclusive as possible because these people were signing up for serial lumbar punctures as well. And so I think that covers the cohort. And, another kind of thing, just getting at Donald's question of anesthetic administration and kind of the cohort characteristics. These patients were mostly highly educated and, 16 years of education on average. So, and not that old, in terms of their age. They were typically, I think our mean age was 66. So sort of lower type acuity and lower comorbidities than some other studies. So just some factors to keep in mind. And then the second question, was that Rania asked about, are 100 patients enough power to find association between sleep apnea and delirium? And I alluded to this in the talk that we had 9 patients test positive within this cohort for delirium. That doesn't give us substantial power. And our primary outcome was actually postoperative cognitive dysfunction or cognitive change at 6 weeks. And so delirium is really a secondary outcome. And so it's not fully powered for delirium incidence. For delirium severity, on the other hand, because you have a wider spectrum of delirium severity changes that include subsyndromal delirium, there is probably enough power, maybe just barely, although we didn't do an a priori power analysis for that outcome, given it was more of an exploratory outcome. But our findings are in line with some of the more recent studies of sleep apnea and delirium, including one by Francis Chung, where in JAMA, where they looked at cardiovascular outcomes. They also measured delirium, and they did it in 1,200 patients, and they found no relationship of sleep apnea with delirium. Anyway, I should probably give some more time to the other questions.
No, that's great. So the next one, I think for Reine, was sleep diary data collected? And is there any insight into information about preoperative sleep deprivation?
Yeah, so we didn't end up collecting any sleep diary data. Instead, what we used was the Pittsburgh Sleep Quality Index. We thought about trying to standardize some of the responses that we received as to that preoperative sleep disturbance. And what we liked about the index is that it does go over some of the things that you might talk about in a sleep diary, such as sleep latency, as well as how many hours you normally see yourself sleeping, if there had been any disruptions due to pain or heat, cold, whatever it was. So it was very interesting for us, because this has been a validated survey, that there were no differences in the results from that survey in the patients that ended up developing delirium as compared to those that did not develop delirium. It'd be interesting to see from a qualitative analysis what that might look like, but from this quantitative analysis of the sleep metrics with the PSQI, we did not see any difference preoperatively.
And that's great. And also, Reine, I just wanted to, I was wondering if you could comment more about, you mentioned that the percentage was quite high was there any difference in the people who were excluded, or who could not, there was a relatively high number of those who couldn't complete the PSG?
So in our analysis of the patients who end up having the clean EEG data as compared to those who didn't, we didn't see any significant differences in terms of demographics or what they showed in the data either. Like I said, the only difference that we really saw was that we had a predominantly male cohort, which is to be expected with cardiac surgery, and then also from a delirium standpoint as well. But we didn't intimate any differences from there. It would be interesting to see if any differences might be found with the larger cohort, and if there might be something to be said about the small cohort that we had in terms of whether it was diversity or other issues. Our cohort was very homogeneous, and being able to do it at another center or diversify the centers that we're using, I'm curious as to whether or not we would see any of those changes. But based off of what we had, we didn't.
Great, very interesting. So I guess the next one was, for those who evaluated delirium, did you collect data on the different types of delirium, hyperactive, hypoactive, and is categorizing these under the same umbrella term appropriate? And I guess I'll throw that out to anyone who wants to jump in.
I'll jump in because no one's answering. So for our study, we didn't categorize, specifically delineate hypoactive or hyperactive delirium. It's actually quite an interesting question, because I know, like, dating back in terms of the sleep literature, sometimes when people are like chronically sleep deprived, they can get like a hyperactive dysphoria. So that might be kind of what they're getting at in terms of the question. In terms of umbrella term for delirium, hypo versus hyperactive delirium, I think we don't even know enough about delirium itself in terms of risk factors and trajectory of delirium, at least in ICU patients, and probably as well in the postoperative literature, to know kind of what is the differential mechanisms between the two different types. All we know that is that there's associated worse outcomes associated typically, at least in the ICU literature that I know quite well, with hypoactive delirium. but I'm not sure if anyone else has any comments, but it's a very smart question, so thank you.
I think,
yeah, go ahead.
No, I think Dr. Wilcox made some good points. We did collect, we used a 3D CAM delirium assessment tool. So we'll be able to differentiate hypo versus hyperactive, but yeah, I can't cite this specific study, but I know that the patients who develop delirium often will transition from hyperactive to hypoactive. And one concern is we may not see, much of a difference. They may not actually represent clinical phenotypes and could represent a different time of assessment, but it's really an open question. And I think that it's definitely, we will analyze that further in our study, but we haven't been able to do that yet.
Great. And then Donald Coach asks, in cardiac surgical patients, what impact proportionally do ICU sedative agents, bypass times play versus environmental factors in the role of disordered postoperative sleep and cognitive disorders?
Word environment's in there, so I'll take it. I think the answer is we really don't know, and it's a bit of a holy grail for us to know, even for sleep, sort of that a little bit artificial division I put in my talk of sleep opportunity versus circadian cue. I don't, the jury's out. How much of sleep deprivation is circadian dysfunction, we don't know, and how much do all these risk factors, severity of illness, pain, anxiety, the environment, anesthetic, bypass time, how does that influence it? We don't know. The one little piece of data we have is some pretty early on 2000 or so PSG studies in which they showed somewhere in the, depending on what you were measuring, but somewhere in the 15 to 20% of arousals and awakenings on PSG were due to noise peaks. In the two different papers, the peaks, the noise was defined a little differently, but all that to say that if sound is really important, which we think it is, it's maybe a fifth of the sources of arousal, but certainly a lot of other things going on. And so I think those questions are all to be determined.
And I think, oh, go ahead.
The only thing that I might add to that is also, particularly as we looked at the cardiac surgical patients, although we didn't look at postoperative sleep, what I can say from a cognitive disorder standpoint, what was interesting in our cohort was how high the rate and incidence of delirium was postoperatively. As I said, normally we look at percentages that are more in the teens, and our cohort was looking at like sometimes 45% to 50%. And what we found is that in the literature, it does show that cardiac surgery patients tend to exhibit higher rates of postoperative delirium, bringing those numbers up from anywhere from the teens to 26 up to sometimes 50% recorded in the literature. So these questions about bypass times and also sedation, medication use could be very well linked to why we see those differences in this cohort. But again, as Dr. Knauert said, more information is needed.
Yeah, and I would just echo that, indices of operative insult are, often found to be associated with delirium severity, whether it's, surgical duration or amount of blood loss or transfusions. And so I think, I don't know of a study that necessarily looked at bypass time, but I bet there is one that shows that it's related to delirium severity or delirium incidence.
I think Karthik Raghunathan has an interesting question about sleep disruption in, I guess, physicians, and whether there are, especially those who have no limits on the number of hours they work in training, and is there a simple test that can be administered to a provider to see whether they're sleep deprived in sort of a sleep breathalyzer? I mean, I think that's another body of work that certainly we are of a group that's most vulnerable in our sort of a whole environment, and the way we're set up to work is probably not conducive to some of the best sleep practices, and we're probably all walking around misaligned from a circadian point of view. And I think there's some work that's already been shown and led to resident work hour restrictions all over the world, who've shown even a 24-hour call has led to increased errors, etc. So that's very interesting. And I think whether if we ever get surgery have higher risk of delirium, I don't know. Next, we have
you have like months and months of data on your smartwatch, right? Like you have a beautiful like histogram that you could plot out of like how sleep deprived you've chronically been on and off for like the last 2 years during the pandemic, probably.
And I don't know if anyone wants to go through a lumbar puncture, but if they want, we're working with CSF, so instead, I don't really necessarily work with breathalyzers, but of any residents who want to undergo lumbar puncture, I'll write up an IRB and collect some CSF on sleep deprivation.
We have Jean-Francois Pité. We have shown that cytotoxic lung endothelial amyloids cause severe hippocampal dysfunction in vitro and live mice secondary to bacterial or viral lung infection. These cytotoxic amyloids are also present in the BAL fluid, plasma, and CSF in ICU patients who present with a nosocomial infection. Would it be a potential mechanism for the later development of dementia in these patients?
Sorry, go ahead, Michael.
I just felt like I should take it just because he mentioned biomarkers, but I think these are all really good questions that we're doing some proteomics in the cerebrospinal fluid, and we have seen some postoperative increases in like serum amyloid proteins that get into the CSF. It's possible that some of these amyloids are causing cognitive dysfunction and delirium from an acute phase reaction due to surgery and or an infection. But I think that the downstream mechanisms in humans are really hard to determine because brain tissue is so inaccessible, and that's why we go to extreme lengths to get cerebrospinal fluid.
If I can add to that, Jean-Francois, there's a lot of good data like that's associative, right? Because at least in cognitive impairment, there's a lot of hippocampal atrophy, and there was a lot of good data that's coming out. And Wes Ely's group at Vanderbilt is actually doing a post-mortem autopsies on like COVID patients and looking at the amount of degenerative proteins that are present, so amyloid, tau. We also have, we're just looking right now at our neurofilament 1 data, which is also associated with neurodegenerative diseases. And there's a reasonable amount of data in the existing literature looking at kind of persistent pro-inflammatory markers and then kind of worsening kind of persistent cognitive impairment. So I think that there's a lot of people who are thinking similarly to Jean-Francois. It's just very difficult to prove it in humans. So the transition kind of from animal to human models, but the study I do know about is the one that they're doing at Vanderbilt. But there is some data that's coming out, at least on neurofilament in terms of other prognostic markers for dementia.
Great. We have Kendall Smith. Since the ICU environment seems to be highly disruptive to sleep, curious to get general thoughts on how to interpret postoperative data that spans several environments.
Sorry, just not quite sure, Kendall, if you could maybe put in a clarifying question. Is it how to sort of, I imagine maybe that you're speaking to that these patients are moving through a PACU, maybe an ICU, maybe a floor, or my one, I guess I'll make a general comment about how to measure the environment, which is we really use high frequency every 10 seconds, every 1 minute, every 30 second as a yeah, I mean, I think it's very different. And I think I mentioned briefly that we don't really know what aspect of noise is most disruptive. We are suspicious it's variability, right? So if you're at some level that's pretty constant and it jumps up, that probably is likely to cause arousals and awakenings, and that's probably our closest link to delirium. But also, if you dig into, for example, the wind turbine or airport or traffic literature, you can see that constant noise over weeks to months is troublesome. My instinct for ICU and post-op is that that's not as relevant. And so we really look at things like loads, like average sound per hour over how many hours, average light per hour over how many hours, and so on, to try to get these continuous variables that act like a dose or a duration. I'll stop there. I know we're getting towards the end, but hopefully that's helpful.
Yeah, I think we can continue over a little bit if there are still questions. The next one was for Reine Ibala. How was the PSG data adjusted for sedation and mechanical ventilation? Great talks.
So for ours, we ended up removing the PSG prior to surgery. So one of the things that we did do was look at sedation, whether it was through propofol or other sedatives, and just did a chart review of those and including them in our analysis to be able to compare whether or not there was a significant difference between those that developed delirium versus those that did not. Outside of that, we also had some operative EEGs that we ended up looking at later, but not particularly for this study. We didn't report it here. That being said, looking at the amount of time that patients were on cardiac bypass, looking at the different sedatives that they received intraoperatively, we didn't see any significant differences. Our p-values were all above 0.1 at that point in time. And so not seeing any significant differences in the differences of sedation and also bypass that are non-delirious versus delirious patients had. In terms of mechanical ventilation, all of our patients ended up being ventilated, but then we ended up excluding those that were not taken off of mechanical ventilation after 24 hours, mainly because we wanted to continue getting the best data that we could as to doing the delirium assessments. So that's what I would say as to that question.
I think Karthik has asked about the effects of caffeine on neuroinflammation, and could this be a safe, inexpensive treatment in the ICU?
I don't actually know whether caffeine reduces neuroinflammation. I don't know if anyone studied that in humans. There was a recent study on caffeine and perioperatively, and it did reduce delirium, and it was associated with some frontal alpha power shifting in the EEG. So it has potential as a therapy for delirium modification, but I'm not sure about the ICU setting if it's been tested. I don't know if any other panelists here know much or have heard any other studies about caffeine. Be interesting.
No, never say never. I think it's interesting because I think we've not looked at wake, and Liz and I have recently been talking about this quite a bit. So wake might be a really interesting target in the medical ICU and probably postoperatively as well, but not that I'm aware of. They use it, I mean, they use it in the pediatric, but for very different reasons. So.
Yeah.
I think the only thing I'm aware of is Philip Lasides at I think Michigan. He's run a trial on it. I'm not sure where that's at. So there's someone testing that, so that's interesting. All right, so last few. For Dr. Wilcox, what if you separately analyze data from patients who did not survive for 12 months? They said maybe the N of 22. You mentioned that survival itself might affect the results of this study.
Good question. So what we did do is we analyzed to see if there was a difference in baseline characteristics between, like in terms of pre-existing sleep and cognition in the patients who survived versus did not. Of course, we were worried that because we were looking at EEG and biomarkers that potentially just the severity of illness was basically predicting whether or not people were going to have like subsequent sleep and cognitive impairment. So that's what I meant by kind of a survival effect. Of course, the patients who were the sickest died. Our mortality in our cohort who survived just to ICU admission, right? So because we consented 150 and just over 100 survived to hospital discharge. And then out to 12 months, again, we had 40% attrition because like more patients died. And that's like just a marker of how sick our patients are, right? Because they get readmitted for whatever their admitting diagnosis was and complications. And so are there opportunities, which is what probably most of the panel and including all of the attendees are really passionate about, like if we improve sleep, right? Because there is a tie between circadian rhythm and your immune system. So if we can somehow modify that to kind of like make you more resilient, can that prevent you from being rehospitalized or suffering significant morbidities where you can't return to work or you can't function? So I think that these are like really key questions that are very patient-centered that we're all trying to answer.
Elizabeth, related to that, did you mention how many of your cohort developed delirium, and therefore did you look at that subset where their sleep trajectory is worse than the overall group?
Yeah, so we didn't actually look at their sleep trajectories. That's a good question in terms of the patients who were delirious. I will say that these studies are very challenging because like when you do a delirium assessment, like once a shift, right? Like what does that actually mean, right? Because depending on, you know, at least at our institution, we do it at 8 a.m. and 8 p.m. because that's when the nurses do their assessments. And I haven't seen any study where they're kind of consistently looking at delirium assessments. So like Michael's cohort, they have some type of like videography that they have, which might be able to be helpful in terms of type of delirium. But I don't think that we have a really good, just like we don't have a great, Melissa and I would kill for like a breathalyzer that would tell us how good people's sleep are, because we spend a lot of time talking about how to measure sleep in the ICU and then in the post-ICU phase. But like, how do we measure delirium, right? Like both of these kind of variables are really challenging to measure, right? And like, you know, deciding on the time point, and is it more important early or is it important late? Like these are really important things that everybody who's working in this field is trying to answer. And so like we're trying to, like some other groups, work on like kind of an EEG measure for early prediction of delirium. So, you know, we now have monitors in our unit where we can monitor, you know, EEG continuously. So can we actually pick up how often our patients are truly delirious? Because, you know, it's really dependent on our measurement system. And that's like measurement bias, like, because like I just didn't capture their delirium potentially.
Yeah, there's a huge need for better delirium measurement. You know, whether some sort of continuous monitor would be great. I mean, I don't know if you were referring to me, but the 3D CAM is really just a delirium assessment tool and a questionnaire that we do twice daily. But you know, it requires a lot of personnel effort to go do these assessments, and even though they take about 5 minutes each, you know, there's still some time, and especially if a patient is delirious, those assessments end up taking longer, and there's more nursing activities to kind of manage around. It's a huge problem, and you know, developing some sort of automated tool, I mean, would make studying this so much easier and probably more rigorous as well.
For sure.
All right, that's wonderful. And I think there's just the last comment. Comment on performance of autopsies. I do believe postmortem is preferred over pre-mortem.
Oh, sorry. Yes, postmortem.
Very good. All right, I think that's, oh, go on.
Oh, I had a question for the panel, if I'm allowed to ask a question. I don't know if we're way over, but do you all think that maybe patients who have like increased sleepiness and have longer sleep duration, that they're more prone to the effects of in-hospital sleep disruption? It sort of occurred to me throughout listening to all your talks that maybe this like represents like a really vulnerable group, that these patients have a higher sleep need, and maybe they have trouble getting that extra sleep that they need in the hospital setting, and that leads to them being at higher risk for delirium.
I was definitely curious about that. And I think that one of the things I struggle with is the need to, I know people in the chat were talking about preoperative sleep measurements, and to some extent we're very limited in terms of using EEG often the night before. So even in our cohort, we were trying to do it in hospitalized patients and doing non-emergent analysis, but a lot of these patients aren't there for weeks before. We're getting a very acute look at what your sleep disturbance is. So if we could find with some machines or have better EEGs and PSGs to be able to use and bring for home sleep studies and be able to understand what does your normal sleep look like outside of the hospital so that we can compare that to this acute change in the hospital and better characterize what the hospital is doing to the sleep of these patients. In reference to your question, Dr. Devinney, that would be really interesting to find out.
Yeah, and anecdotally, I feel like a lot of patients I take care of in the ICU that end up getting delirious, they're always like, oh, my sleep was terrible at home. And then you'll hear from a family member like they sleep all the time, but at weird times. And I just don't know if that, maybe we could identify an at-risk cohort, with some sort of sleepiness or sleep need assessment, really. But it seems almost disentangling that from neurodegenerative disease will also be challenging, because I think a lot of recent data has shown that longer sleep durations associated with neurodegenerative disease.
Yeah, so I think with your study and the Reine's, there seems to be this the need for sleep as a potential marker, whether that's causal or an unmasking of neurodegeneration or baseline cognitive problems is we have to tease out. And certainly some of the stuff I've looked at, indeed, the excess sleepiness and long sleep duration were, related to future risk for delirium. Again, what tease out, is there any causal intermediates, or is that a reflection of other chronic diseases that put them at risk for delirium? We have to tease that out. Yeah. Okay. All right. Well, just on behalf of everyone, I thank everyone for being present, and thank all the panelists for putting this together. It was a really stimulating, wonderful set of talks. So thank you so much.
Thanks.
Thanks.
Thank you all.